Hey, hello everyone, and welcome to this Cybersight webinar. I'm Timothy Lai from Hong Kong, and I'm going to talk on two topics today. One is on polypoidal choroidal vasculopathy, or PCV, and the other is on macular complications of myopia. So polypoidal choroidal vasculopathy, or PCV, is generally considered as a subtype of neovascular AMD. The disease is highly prevalent in Asian populations and accounts for about 30 to 40% of Asians presenting with neovascular AMD. And it is characterized by multiple recurrent episodes of serous or hemorrhagic PED and exudative maculopathy. As you've seen in this fundus photo, you can see the orange nodule is a polypoidal lesion, a lot of hard exudate, and also serous macular detachment. Inferiorly, you can see some subretinal hemorrhage as well. The lesions, they are called the polypoidal lesions, and they are best seen on indocyanine green angiography, or ICGA, as seen in this picture here. So how do we diagnose PCV? We usually use one of the criteria, and the most commonly used is the average diagnostic criteria, which is the first multicenter randomized controlled trial for the treatment of PCV. So this is based on the central reading center grading of confocal scanning laser ophthalmoscope-based ICG angiography. And you have to see presence of subretinal focal ICG hyperfluorescence within the first 6 minutes of ICG injection, plus any one of the followings, including branching vascular network, pulsatile polypoidal lesion, nodular appearance when they are viewed stereoscopically, presence of hypofluorescent halo, orange subretinal nodule on color photograph, and association with massive submacular hemorrhage. And I'll go through these one by one later on. So why is ICGA the best diagnostic tool for PCV? This is because the ICG molecule, it is highly protein bound and does not leak through the choriocapillaris and will remain in the choroidal vessels. It can therefore allow better visualization of the choroidal circulation, much better than the fluorescein angiography. And also the infrared stimulation emission spectra for the imaging can allow the light transmit through better through the RP, through some hemorrhage, and also thin fluid or exudates. So ICG has been the gold standard investigation to differentiate PCV from typical neovascular AMD CNV. In CNV, you usually see an ill-defined hyperfluorescent plaque. In the late phase, early phase is just an ill-defined hyperfluorescent, and the PCV, you will see the nodular polypoidal lesions with the branching neovascular network. In terms of fundus appearance, these cases usually will have multiple recurrent serous retinal detachment or pigment epithelial detachment. And here you can see this orange nodule, and there's usually a notch within the edge of the PED, and you don't have the typical soft drusen you see in neovascular AMD, and also you do not get the massive subretinal or sub-RP hemorrhage. This is another clinical appearance of the PCV. You can see this patient on the right eye, and you can see the orange polypoidal lesion with the hard exudate and also exudative maculopathy. Left eye already had a previous episode of subretinal hemorrhage, and therefore you get a scar formation. And this is taken from a very good paper from Thailand by Dr. Verapon Chikamonko. And you can see that here you can see the orange polyp and also the polypoidal lesions as orange nodule on the color fundus photographs. So you also sometimes get massive subretinal hemorrhage greater than 4 this area. And also hemorrhagic PED, and there's usually also a notch in this hemorrhagic or notch PED. In terms of ICGA pattern, I mentioned before, is a diagnostic tool of choice, and therefore you get these polypoidal lesions with this branching neovascular network. Here is also, you can see this, there are 2 polypoidal lesions here associated with this PED. Another case, a color fundus photo showing this large area of notch PED and subretinal hemorrhage. And you can see also the branching vascular network and the polypoidal lesions on the upper edge of this PCV PED. If you use the color, the confocal scanning laser ophthalmoscope, you can also get very good contrast in these pictures. And you can see that here the polypoidal lesions showing the early and the late phase of the ICGA. Here, another example, you can see these polypoidal lesions can occur as a single polypoidal lesion or in a cluster, like here is like a bunch of grapes. On 4C angiography, usually the PCV lesion will appear as localized or diffuse stipple hyperfluorescence, which might not be distinguishable from occult CNV in neovascular AMD. And also classic 4C angiography has also been described. So in the middle, you can see this is basically a patient with occult CNV kind of leakage. And on the right side, you can see the ICG showing the polypoidal lesion with the associated branching neovascular network. Another example of a 4C angiography, you can see this is a multifocal pattern of leakage, which you cannot see the polypoidal lesion very definitely in this case. Another very important diagnostic tool that we use for PCV nowadays is spectral domain OCT. We can evaluate the morphology of the PCV changes. You can see the polypoidal lesion appearing as an anterior dome-shaped elevation of the RPE layer together with the presence of subretinal fluid and PEDs. And the branching neovascular network, they usually can be visualized as two reflective layers, and we call them the double layer sign. So this is representing the elevation of this neovascular lesion. And a spectral domain OCT is also very useful to monitor these patients' treatment response. So with ongoing treatment, we can decide whether to retreat the patient or not. And we can also use the enhanced depth imaging mode to look at the choroidal thickness. And in relatively young patients, we can see that many of them will have a thick choroid because PCV is considered as part of the pachychoroid spectrum of eye diseases. So just look at some of the SD spectral domain OCT features of PCV. So you can see the PED, which characteristically is a sharp peak or thumb-like or notch. It can also be an M shape with a hyperreflective ring. You can also see the double layer sign, a thin separation between the RP and Brooks membrane. Thick choroid, usually we consider it as thick as a 300 micron of subfoveal choroidal thickness or more. And also the on-fast OCT can see the RP rings. Here again is from taken from the paper by Dr. Chitamonko. You can see that what is the definition of sharp peak PED? If you measure this angle from the edge of this polypoidal lesion, the elevated PED, to the RP layer, anything greater than 70% would be considered as a sharp peak PED. So in a typical neovascular AMD picture, you can see on the top here, it's around about like 45 degrees. So this PED, it's not basically it's a fibrovascular PED due to AMD. One in bottom, you can see this is very sharp peak, almost 90%. And this is a typical PCV kind of PED. You can also see multi-lobulated or M-shaped and notch PED. Also this double layer sign and also the hyper-reflective ring. So this is representing the polypoidal lesion. If you look at some of these features, because many centers, they do not have the ICGA, you can still use the OCT to make quite a good diagnosis clinically. So fundus photo, if you see this notch or hemorrhagic PD, you get an area under the curve of about 0.77 accuracy. With a spectral domain OCT, if you look at all the individual features, PED notch, sharp PED, hyperreflective ring, around about 86 to 90%. And when two of them were present, you get about 93% accuracy. So it's pretty good. So as I mentioned before, enhanced depth imaging would be useful to look at the choroidal thickness because the conventional OCT, they mainly focus on the retinal levels, but with the spectral domain OCT using the EDI enhanced depth imaging mode, you can go deeper looking at the choroidal layer. And you can also see that the choroidal thickness in different diseases. For example, in this study from Korea, they measured patients' choroidal thickness in age-related macular degeneration, neovascular AMD, PCV, and CSC. And you can see the mean choroidal thickness for CSC and PCV, they are much thicker than control or in AMD cases. So PCV and CSC, central serous retinopathy, they are related to the peglochoroid disease spectrum. And with the on-fast OCT, we can also see that these cases will have some dilated choroidal vessel, we call them Pecki vessel, as well as the RP elevation. So in order to verify the changes in the OCT as a diagnostic criteria, a group was led by Jamie Chang from Singapore, Woon Ki Lee in Korea, and myself. We formed this APOIS, which is the Asia Pacific Ocular Imaging Society work group on PCV. And together with many experts throughout the world, we formed consensus meetings to shortlist some of the non-ICJ features for PCV and then validated the findings. And this was published back in 3 years ago in Ophthalmology. So we recommend some terms to standardize their nomenclature. So the term on multimodal imaging now for the polypoidal lesions and also for using the branching neovascular network. And the 9 features that we looked at include the sharp peak PED is shown here, sub-RP ring-like lesion, and here is the complex multilobular PED, like an M-shaped PED. The double layer sign representing the branching neovascular network, thick choroid with dilated hilar vessel, fluid compartment. You can see the fluid, mainly the subretinal fluid, and also RP complex elevation on the on-fast OCT. And for fundus feature, we look at the extensive subretinal hemorrhage or the orange nodule. And looking at all these 9 features, we graded many photos and found that the best features to diagnose PCV are firstly, the sub-RP ring-like lesion. Second is the on-fast OCT elevation of the RPE layer. And also thirdly is this sharp peak PD, and they had a very good area under curve from 0.79 up to 0.83. And clinically, you can quite reliably use these two to diagnose your PCV cases without the use of ICGA. More recently, people have also used the OCT angiography to look at this, and you can also use the combination of structural OCT and OCTA to diagnose PCV, and this also gives you a reasonable sensitivity and specificity. As you can see here, you detect the flow signal within the polypoidal lesion, and you can see that both these B scan OCTA and as well as the on-fast OCTA can detect some of the polypoidal and branching vascular network lesions. Okay, let's go for the first polling question. So the polling question is, which of the following is not a feature suggestive of PCV? So first one is polypoidal lesion in ICGA. Second is sharp peak PED in the spectral domain OCT. Third one is nodular orange subretinal lesion in fundus photography. And the last one is confluent soft drusen in fundus photography. Very good. So we can see mostly 80% got it right. So we do not typically see the confluent drusen in fundus photography because those are the signs that you typically see in the wet AMD, in the neovascular AMD, or even dry AMD cases, but not in PCV cases. Right, so let's go for the treatment. So why do we need to treat PCV? For example, in this natural study we performed in our Asian population, we looked at 32 eyes of 32 patients with PCV without treatment, followed them for at least 12 months. And these patients had a mean follow-up of about 5 years. And you can see there was a significant reduction in visual acuity and proportion of patients with 20/200 or worse vision increased from 28% to 53%. And the main causes of poor vision included hemorrhage, RP atrophy, or scarring, and that's why we need to treat our patients. So how can we treat them? So the most simple one is the direct focal laser, and it has been used for extrafoveal PCV. So with these polypoidal lesions well away from the fovea, we can use the laser to burn it. But of course, there might be some risk for it, including RP damage, subretinal, or even vitreous hemorrhage. Another alternative technique is to use the ICGA to look for the feeder vessel, but it's technically very challenging. This is example what we used. We used a green laser here, and then we applied it to this extrafoveal polypoidal lesion. And 2 months later, you can see this polypoidal lesion completely gone on the ICGA with good improvement in visual acuity. And over 3 years, this was still stable, but there was some enlargement of the scar. So if the lesion is well away from the fovea, we can still consider doing thermal laser. But if it's closer to the fovea, then we should not do it because it can damage the fovea. So what's the best treatment nowadays? So we have 2 very good randomized control trials providing level 1 evidence on the treatment of PCV, which are the Everest 2 study and the Planet study. And the consensus we have now is that the treatment, usually it's depending on the lesion characteristics, and we can either use anti-VEGF monotherapy using ranibizumab, aflibercept, and nowadays we also have newer agent like faricimab, or the combination treatment combining the anti-VEGF plus verteporfin PTT, and I'll show you some of the results from these key trials. The first one is Everest 2, which was a 2-year study, double-mask, multi-center trial. And so basically, it compared the use of ranibizumab monthly treatment versus ranibizumab treatment with the use of combination verteporfin PDT. So the primary outcome is to look at the change in visual acuity. And you have other secondary objectives, which include looking at the change in central retinal thickness, the polypoidal regression rate, number of treatment, etc. So the study randomized over 320 patients, half of them to the combination arm, ranibizumab plus verteporfin PDT, the other arm to ranibizumab alone. And you can see that prime endpoint is 12 months. And by the later of the study, some of the patients were switched to the combination arm because it showed a superiority in terms of using combination therapy. If you look at the change in visual acuity at month 12 and month 24, both groups did well. Both groups improved the vision with loading dose of treatment and then as needed treatment. But the improvement was more marked in the combination arm. So for the patients who received ranibizumab plus initial PDT, they had about 9.5, 9.6 letters of visual acuity gain. Whereas patients who had ranibizumab loading doses and then as needed treatment, they gained about 5.5 letters. And this was like a 4-letter difference. In terms of polypoidal lesion regression, also much higher for the combination arm. So first year, about 70% for the combination arm. At 24 months, about 56%, whereas ranibizumab around 30 to something percent first year and 26% in the second year. By doing combination treatment, we can also substantially reduce the number of ranibizumab injection. So you can see 30% of patients only needed 3 to 4 injection in the combination arm compared with 13% for the monotherapy arm. And the median of number of treatment over 2 years is only 6 for the ranibizumab plus PDT combination arm, whereas for the ranibizumab monotherapy arm, it's about 12 injections. So it can reduce the treatment burdens quite substantially. And in terms of the number of PDT, 40% only had 1 PDT treatment at the initial onset. How about the other study? So the other one is the Planet study, which evaluated another anti-VEGF, which is aflibercept. So the study's design is quite different. So Planet, all patients had 3 monthly initial dosing of aflibercept first, and then they were randomized to 2 arms. One is to the rescue PDT arm, or with active rescue PDT. The other is with active with the sham PDT. But both arms would still be having ongoing aflibercept 2 milligram every 4 weeks, and then extension. So, and then they would be at the 1 year, they would be treated as a treat and extend. So many patients did not receive the rescue treatment because the rescue criteria, they were quite stringent. So you can see if they were only allowed to have rescue treatment if their vision is less than 73 letters and they had a substantial visual loss of 5 letters or even 10 letters, and then OCT showed new fluid or persistent fluids. And then plus, if they only had ICG showing active polyp, then they could have rescue treatment. But ICG was not performed in all patients at week 12, and so only about 17% of patients throughout the study were eligible for rescue treatment. And you can see that some patients had also a lot of the CST was comparable, but these patients had a worse patient the vision to start with. But nonetheless, if you look at the results on the patients with treatment, either aflibercept plus rescue or active PDT or sham, they did similarly well, so about 9 to 10 letters. Whereas the polypoidal recurrence rate about 30%, so not as high as what you saw with the combination treatment in the Everest 2 study. Number of injection was about 12 injections in the first year. And here you can see that both study gained vision at the end of the study. So number of treatment about 12 injection over 24 months. So a lot of differences between the 2 studies, Everest 2 and Planet. So you can see Everest 2, mainly a prompt treatment of the PDT in the initial onset, whereas Planet, you loaded them with 3 aflibercept injection first, and then decided whether rescue treatment is needed or not. So you cannot really directly compare the study. So at the moment, if you look at the Japanese study, they still can recommend either for PCV cases, you can still do anti-VEGF monotherapy or use a combination of PDT plus anti-VEGF. But if the patient's vision is relatively good, they use 0.6 as the cutoff, then anti-VEGF monotherapy should be considered instead of using combination therapy. And nowadays, most doctors, I would say, because of the issue with getting the verteporfin drug in many countries, and also the lack of laser machines for the PDT, most places are actually just doing anti-VEGF monotherapy for the patients. But patients, because they will have ongoing disease activity with stopping the treatment, so treat and extend treatment is highly recommended for the PCV patients. Okay, so just to summarize PCV, so with the rapid improvements in imaging technologies, including spectral domain OCT, OCTA, we can make better diagnosis in monitoring our PCV patients. And based on the phase 4 study, the Everest 2 and the Planet study, you can see that both anti-VEGF monotherapy and combined anti-VEGF plus verteporfin PDT, they can improve the patient's vision quite well. Okay, now let's go to the second topic of today, which is on myopia, pathologic myopia in particular, because it's associated with various retinal and macular diseases. So how do we define pathologic myopia? Basically, you get a globe elongation and refractive error of at least -6 diopter and an axial length of greater than 25.5 millimeters. Some people use 26. And it's highly prevalent in Asian again. So especially in East Asia, around about 10% of Asian populations. And with the disease, because of the axial elongation of the eyeball, it will cause mechanical stretching and thinning of the choroid and the RPE layers, causing all the pathology. And therefore, you get increased risk of many retinal complications, including retinal degeneration, like lattice degeneration, and then this can form retinal tears and predispose you to retinal detachment. You can also get abnormal shape of the eyeball, so getting posterior staphylomas or dome-shaped macula. You get also retinal atrophy, lacunar cracks, myopic CNV formation, which is one of the focus that we'll talk on, and the other is myopic traction maculopathy, including myopic foveal schisis and macular hole. So previously we did a study in Hong Kong looking at our population with all very high mild patients, so 337 patients, mean age quite young, 36 years, with a mean spherical equivalent of 10 diopters. And among these patients, 11% were actually of eyes were found to have one or more posterior pole lesions. And after correcting the axial length and refractive error and older age, they were significantly associated with more posterior pole lesion. And the current standard to grade the myopic macular changes is using this META-PM study group classification. So they classify the patients as category 0, which means no macular lesion. Category 1 is those with tessellated fundus. Category 2 are those with diffuse chororetinal atrophy. Category 3 are those with patchy chororetinal atrophy. And the fourth one is the most severe, is the macular atrophy. And at any stage, you can also have some plus lesions, including lacunar cracks, choroidal neovascularization, and Fuchs spots. Here are some examples of the various category. So this is patients with tessellated fundus. Here, patient with diffuse chororetinal atrophy. Here, category 3 is the patchy chororetinal atrophy. You can see many of these patchy lesions. And finally, it's a very severe macular atrophy. You can see the underlying scleral vessels here because the choroid is completely gone. And with any stage, you can also get associated plus lesion. Here is lacunar crack, CNV formation, and macular hemorrhage. So more recently, the International Myopia Institute, we also published another white paper looking at the progression of these diseases. So high myopia, you can get normal fundus and then get a tessellated fundus. But with pathologic myopia, you get all these changes, including the diffuse retinal atrophy, macular atrophy, patchy atrophy, and then this is signifying progressive choroidal thinning. And with these, it can cause a myopic macular neovascularization with associated either patchy-related macular atrophy or the myopic CNV related macular atrophy. So in terms of macular complications, there are a few that you should be aware of. Firstly is the myopic traction maculopathy with either the myopic foveal schisis type, and more severe, you can also get the myopic macular hole type with retinal detachment in the very severe stage. And the other, of course, is myopic CNV because these are treatable. So let's look at myopic foveal schisis first. So what is myopic foveal schisis? You get axial elongation of the eyeball, and therefore some mechanical splitting of the retinal layers in the macula. And in high myopia patients, you can see that this in up to 34% of patients, and patients can complain of metamorphopsia and also blurring of vision. If you don't treat them, these can cause myopic macular hole and retinal detachment. So the pathogenesis is because of the very elongated eyeball, and then you get the vitreous traction, causing this splitting of the internal limiting membrane and the abnormal contour, and also the chororetinal atrophy. Then due to posterior staphylomas, so you do not get a very nice shape, and therefore they cannot adhere very well. In terms of natural history, a study has been performed to look at 29 eyes with myopic foveal schisis, been followed up about 2.5 years. You can see that over these 31 months, 20 eyes, that is about 70% of eyes can have vision worsening, whereas the remaining 30% had some stable vision. And with this, 9 eyes actually developed macular hole, and so 6 of these actually had a full field detachment prior to the macular formation. And surgery was performed in the 11 eyes and resulted in significant visual improvement. Another study performed in Singapore, they also look at 50 eyes followed with the spectral domain OCT for about 12 months. And you can see that they had different types of morphology. So entire macular retinal schisis, the photoreceptor detachment, full field ellipsoid zone disruption, partial thickness macular hole, and full thickness macular hole. The poorest vision types are those with entire macular retinal schisis. And with a follow-up of 31 months, about 28% had worsening of 2 or more lines of vision. So when should we perform surgery? So some patients, they can have a quite good vision maintaining without any reduction for many years. But surgery is still indicated because of the potential progression. So when should we do the surgery? Usually we do it when there's a presence of premacular structure like a tractional ERM or retromacular traction, reduced vision or distortion of vision. Functionally, the patient is having quite symptomatic metamorphopsia. And if you do the OCT assessment, you see full field detachment, then that's a good indicator that the patient will need surgery. For surgery, we can do a vitrectomy with or without iron peeling, and also with or without gas or oil tamponade. Macular buckle has been performed, so suprachoroidal buckle has been performed, and sometimes we do a combined vitrectomy and buckle. I'll go through some of these steps. So firstly, it's the suspended vitrectomy with iron peeling plus gas. So the iron peeling, it's mainly to ensure that you can get complete resolution of the residual vitreous cortex on the macula. So that would reduce the traction due to these premacular structure. And also removing the stiff RM can also facilitate the retina to conform the posterior staphyloma. And the results are generally quite favorable. About 80% of the patients will have visual improvement after the surgery with the resolution of the myopic full field schisis. So this is an example that we published over 15 years ago now. You can see a small series, about 9 eyes with the vitrectomy, epiretinal membrane peeling. The patient's vision improved quite well. Mean improved from 20/80 to 20/50, and 78% of eyes had complete resolution and 22% had partial resolution. Some study they did not use gas, so they just performed the vitrectomy and iron peeling. They also classify patients into 2 groups, one with full field detachment, the other with no full field detachment. And with the surgery, they show that 100% success rate after the surgery. And in terms of visual acuity gain, those with full field detachment actually gained the best, so much higher significant improvement in vision compared with the no full field detachment, which basically stay similar. So they suggested that surgery should be performed in cases of full field detachment. So this is an example that we operated on. Patient, you can see epiretinal membrane, also full field detachment at the macula, 20/70 vision. We did a vitrectomy and membrane peeling, and after surgery, 2 months later, complete resolution of the myopic full field schisis, and vision improved to 20/30 as well. Another series look at these patients had full field detachment, retinal schisis or macular hole, and they again found that full field detachment cases had the most improvement. And by the time you had macular hole, no significant improvement in vision could be obtained. So that's why you should perform these cases when there's full field detachment instead of waiting for the macular hole formation. And sometimes we do not peel the ROM because of the potential surgical damage and the potential for formation of an iatrogenic macular hole. And so a few studies have been performed showing that suspended vitrectomy without peeling can still result in good success. But this meta-analysis showed that the anatomical and visual outcomes were similar with or without iron peeling. But in terms of macular formation, because the numbers were quite small, only about like 10 or 20% in some series, but many series did not have any. So it still remained unclear whether peeling the iron would cause macular hole formation or not. Nonetheless, some groups, they advocated the use of foveal sparing iron peeling. So you just peel the IOM around the around the fovea instead of not leaving the central part behind. And so this will hopefully preserve some of the molar cell at the center to prevent macular formation. And so again, you can perform it with or without gas because it's still controversial because sometimes they feel that if you have foveal detachment, you put in gas, you can actually cause a macular formation. In terms of macular buckle, personally, I do not have any experience because from the Japanese group, they actually do not recommend it these days because of potential long-term retinal atrophy. These patients with high myopia, they already have a thin choroid. If you put something behind it, it can further exacerbate the retinal atrophy. The other condition you have to treat is the myopic macular hole, because if you don't treat this, you can cause it can progress to retinal detachment. So you get various options, again, vitrectomy with gas or silicone tamponade without iron peeling, and then sometimes we also do RM repositioning. Macular buckle and scleral shortening surgeries have been performed, but these are quite tricky to close because the choroid, they are quite thin and you don't have much tissue as well of the because of the elongation of the eyeball, the contour is not correct, so many patients may still need multiple surgery. So in our series, previously we used vitrectomy and high density silicone oil. We got a success rate about 83%, but vision still remain quite poor despite the successful surgery. Another study, they also look at the silicone oil. Here, 100% with heavy silicone oil after removing about 87%, standard silicone oil about 60% reattachment rate, and after removing silicone oil about 53%. But again, vision did not improve significantly because many of patients had quite a severe macular atrophy. And another study, they used IOM repositioning. So put the RM as a scaffold over the macula and then use some autologous blood, and they found a bit of visual improvement. Here another study with the inverted RM insertion, about 100% success rate in this group compared with without RM insertion, only about 35% success rate. So you can see still quite controversial what kind of procedure should be performed, but nonetheless, generally we perform vitrectomy, membrane peeling, and gas injection for these macular hole, myopic macular hole cases. And finally, the topic would be on myopic CNV. So this is quite common in high myopia, occurs in about 5 to 11%, and it's actually the most common cause of CNV in patients under the age of 50. In general, it's also the second most common cause of CNV after neovascular AMD. In terms of incidence, it's around 10% after a follow-up of 10 years. In terms of natural history, so why do we need to treat it? Because these patients generally will have visual decline if we don't do any treatment. There's a very good study performed by Professor Ono Matsui in Tokyo. You can see initially about 29% will have a vision of 200, worse than 2200, but by 5 years, this increased to 88%, and by 10 years, it's almost everybody had a vision of 2200 or worse. And therefore, we need to treat these cases. In terms of treatment, how to manage them. So we can confirm firstly the diagnosis of myopic CNV and then choose an anti-VEGF agent. So you can use a licensed one, ranibizumab, aflibercept in China. We also have Conbercept. Off-label use is bevacizumab or aflibercept. Then you can decide on treatment regimen using PRN. Mostly we use PRN, so 1 or 2 doses and then as needed. Very few patients, if they had like ongoing large lesion, then we might consider loading doses or treat and extend. For investigation, the most important one are fluorescein angiography and OCT. Fundus photo is also useful. Additional tests that you can perform include OCT angiography if you have it. ICGA and fundus photofluorescence are not too essential. So why do we need all these tests? Because you need to know whether the visual loss is due to myopia or due to other conditions which can be associated with myopia, like tractional maculopathy, foveal schisis, macular, which I mentioned before, retinal detachment, dome-shaped macular, staphyloma, or some atrophic changes, various kind of choroidal atrophy. You also want to differentiate the CNV is due to other causes or not, like neovascular AMD, or the hemorrhage is just due to a liquor crack formation. We call them just simple myopic macular hemorrhage, which can resolve on its own. Also punctate in a choroidopathy, multifocal choroiditis, or idiopathic CNV. So these are some of the differential diagnoses. So you see something, retinal hemorrhage. So this is actually simple macular hemorrhage due to lacunar crack formation, not due to myopic CNV. On the OCT, you can see the myopic traction maculopathy and also myopic macular hole detachment. Fluorescein angiography is the most commonly used diagnostic tool, and the active CNV, it will show up as a well-defined hyperfluorescent lesion in the early phase with leakage in the late phase. And sometimes the leakage can be very subtle, and but it might be the only sign of myopic CNV activity. And with the use of FA, you can see the leakage and therefore differentiate from other causes of macular hemorrhage. And usually the hemorrhage is very thin, so therefore myopic CNV would not be masked by this blood. And you can also use the FA to determine the location of CNV, usually subfoveal, juxtafoveal, or extrafoveal. And for spectral domain OCT, nowadays we also use it quite often because it has become the center of care of managing these patients for monitoring the treatment response. And these cases are usually type 2 CNV, so they are above the RPA layer. So when you get the active CNV, you can get this highly refractive dome-shaped elevation. And with the inactive CNV, so after treatment, it can cause a scar and you get this hyperrefractive lesion, which will cause a shadowing effect. So people have done study comparing the use of FA or OCT, and they found that diagnosis of CNV alone can be made with FA in about 61%, with OCT alone about 22%, with both in 16%. And there was no sign of agreement between active CNV, between FA and OCT imaging. So the FA and OCT really, they do complement each other. So yes, in this case, so one of our patients, you can see macular hemorrhage in this highly myopic eye. OCT actually showed the CNV quite well, and also there were some other existing pathology, which is the epiretinal membrane. FA also showed the leakage associated with the hemorrhage. OCTA can be useful, and you can monitor these patients. And it's also been incorporated in some of the protocol. So in here, a study performed in the UK, they look at the patients who had myopic CNV, underwent FA's OCT or OCT angiography, and they found that by combining the two types of OCT, SD-OCT and OCTA, you can get a 97% sensitivity, so quite well. So nowadays they will perform SD-OCT and OCTA first. If it's positive already, they would go for the treatment. But if not available or OCTA is negative, then they'll still do an FA to confirm their diagnosis. Okay, now polling question number 2. So which of the following is not useful for diagnosing myopic CNV? One is OCT, second is OCTA, thirdly is fluorescein angiography, the last one is Humphrey automated visual field test. Good, visual field test is not useful, so most of you got that. So the other are also all quite useful. Okay, so let's go through the treatment. So as I mentioned before, without treatment, many patients will have worsening of the vision. And so this study again showed without treatment, they deteriorated the vision. Again, the same slide. The treatment option wise, In the past, people have done thermal laser and also surgical removal, but these are no longer performed because we have better treatment. So PDT is the first treatment available. It can maintain the patient's vision, but could not improve the vision. But we rarely do it nowadays unless the patient has a contraindication. So most of the treatment now is use anti-VEGF agents as anti-angiogenesis therapy. So why do we use anti-VEGF? Because we've known that the CNV was associated with elevated VEGF level inside the eye, and we've got very good clinical trial experience that it can improve the vision. So as I mentioned before, we have various treatment available, so on-label and off-label treatment. This is a patient who I treated with bevacizumab, so -8 diopters of myopia. You can see FA, very typical type 2 CNV. This is the OCT as well. So gave him 3 injections of bevacizumab, and you can see very good reduction in the CNV on the OCT as well as regression in the FA, and the patient's vision improved from 21/25 to 20/50. And patient didn't need any treatment afterwards. So compared with neovascular AMD, myopic CNV, the treatment demand is much lower. So let's look at some of the clinical trials. So one is a Radiant study, which is the very large study, look at the use of ranibizumab, either guided by visual stabilization. These patients had the injections at day one and also month 2, or second is the disease activity, so just one initial injection, and then looking PRN treatment compared with PDT treatment. So you can see that patient with the ranibizumab, even at 3 months, 10 letters gain for both ranibizumab group compared with PDT group, only about 2 letters gain. And the two, either guided by visual stabilization or disease activity, they actually had a similar outcome at month 6. So nowadays, we would guide our patients using disease activity. So just one injection of ranibizumab, and then the patient would do well. So you can see over 1 year, a very good improvement in vision. Those patients in the PDT group, they were eligible to switch to ranibizumab, and they still gained some vision, but never caught up to those who were treated early. And afterwards, we also did a post-Radiant study, look at the long-term outcome of these patients. So these patients had another 3-4 years of follow-up, and you can see that after the patients exited from Radiance, they still maintain their vision. And so 7 patients required additional treatment afterwards. And these patients with additional treatment, they still gained vision, maintain that level that you observed when they exited Radiance. So in the long term, and ranibizumab treatment was also quite favorable. And you can see recurrence rate around about so 7 out of the 41. So not a lot of patients had recurrence, around like 20%. Another study is the MIRROR study, which looked at aflibercept for myopic CNV. So it's a phase 3 study where patients randomized to 2 groups, aflibercept versus sham injection. So you can see one initial, the aflibercept injection, 2 milligram, and then as needed treatment. The control had a sham for the first 6 months, and then they were eligible to switch to aflibercept. Looking at the patient improvement, so you can see primary outcome, patients treated with aflibercept early, they gained 12 letters. Patients who were treated with sham, they lost 2 letters. And patients at the end of the study, patients treated with aflibercept from the start, they gained 13.5 letters. Patients who were switched to aflibercept, they gained only 3.9 letters. Still some improvement, as you can see, a very large gap. So again, saying that you should treat your myopic CNV patients with anti-VEGF agents early. Again, number of injections very low after the first quarter, like the last 9 months, only median of 0 injections. So treatment demand is very low for these patients. Third one is the SHINY study performed in China. They use Conbercept. Here they used loading doses and then compare the patient loading doses of Conbercept versus sham. You can see 3 injection and then control group just sham initially. And you can see characteristics, baseline comparable, and very similar results from what we saw in Radiance and in the MIRROR study. Rapid improvement in vision with anti-VEGF treatment, and then this was maintained. Also very good reduction in macular thickness. number of injection, about 4 injections, but these patients, they had loading doses, so a bit more injections in SHINY than the other 2 studies. How about the real world? So in the real world, of course, the IRIS registry conducted by the AAO in the US is the best registry for many other diseases, including myopic CNV. And they found that patients either had observation or anti-VEGF treatment. You can see this is 1 week from the index days that they looked at the identify the case. So 130 cases here. You can see the patient's vision improve from 0.5 log per unit to 0.3. So on average about 0.17, 1.7 lines of visual improvement 1 year after starting anti-VEGF therapy for myopic CNV. And if you just observe, did not do anything, no anti-VEGF, they actually lost a bit of vision. And in terms of number of injection, again, very low. Most only had 1 to 2 injections. Very rarely you needed 3 or more injections. So myopic CNV, treat your patient early with anti-VEGF. So in terms of the consensus, we also grouped together to form some consensus on what to do. So myopic CNV, we try to get them in the active phase because this is the time that the myopic CNV can cause damage to the photoreceptor, causing visual loss. So we need early diagnosis and treatment. Once the lesion is getting bigger and already having some fibrosis or even atrophy, then the patient's vision would not be able to be salvaged. So that's why we recommend patients to be referred to a retinal specialist, someone who can do injection, inject them early, do 1 treatment, and then monitor them monthly for a few months, and then at least 3 monthly for the first year in case of recurrences. And this is also another consensus we prepared. So recommendation is that anti-VEGF therapy should be the first-line treatment for myopic CNV, and dosing should be 1 or 3 doses, depends on where you are. Larger lesion, we tend to give 3 and then PRN, but small lesion, 1 injection is enough. Okay, so final polling question. Which of the following should not be performed as a treatment for subfoveal myopic CNV? 1 is thermal laser. 2nd is intravitreal ranibizumab injection. 3rdly is intravitreal aflibercept injection. 4thly is intravitreal cumbersat injection. So which one should you not perform to treat the subfoveal myopic CNV? Oh, very good. So the first one, you should not perform thermal laser. So 80% is right. Fantastic. So we now have anti-VEGF, which is very effective. Okay, so just to summarize, so myopic traction maculopathy and myopic CNV are 2 very important sight-threatening complications of pathologic myopia, and we can do various surgery for treating myopic traction maculopathy. And in terms of myopic CNV, we have very good clinical trial data showing that all anti-VEGF agents are useful for myopic CNV. And in general, they require a very low number of injections. So just treat your patients promptly and monitor them after the initial treatment. So with that, thank you very much. So just show you 2 pictures that in my recent trip to Vietnam, had a very good group of trainees and fellows. So a fantastic experience there. So thank you very much. So we can now have some Q&A. All right, so let's go to the question. So feel free to type your Q&A. So the first one is that question on how can you determine the cause of subretinal hemorrhages, whether they are due to polypoidal choroidal vasculopathy, wet AMD, and particularly when ICGA is not available. So very, very good question. So, so as I mentioned before, many places might not have ICG angiography, and that's why nowadays we do a lot of OCT to diagnose. And if you look at the PowerPoint that I just presented, with the use of OCT, spectral domain OCT, that is, we can diagnose most of the PCV cases, around about 85 to 90%, by looking at various OCT features. So the most important one, of course, the sharp peak PED with the subretinal nodule, and also the on-fast OCT showing the complex RP elevation. So all these features, if you have 2 or more of these, and also the other is fundus photo, you look for those orange lesion. And then if you have 3 or 4 of these features, then it would be highly suggestive of the patients having the retinal subretinal hemorrhage due to PCV. And also, you also look for other features, of course, if you see the patient having a lot of soft drusen, for example, that might be a case of wet AMD CNV rather than a PCV case. But nonetheless, nowadays we mostly use anti-VEGF monotherapy for our patients, regardless of neovascular AMD or PCV. So you still monitor them after the treatment carefully. And the best outcome, of course, is if you can afford the patients to have a treat and extend, because that can maintain a dry macula usually. All right, second question is, how do I differentiate polypoidal lesion from window defect? So another very good question. So window defect, we usually refer to those patients fluorescein angiography with some RP atrophy. So the background fluorescence is coming through. So polypoidal lesions, we do not define them on fluorescein angiography. We only define them on the ICG angiography, because that's the term that we use for ICG angiography. And you can see the polypoidal lesions are those who actually had a nodular hyperfluorescence within the first 5 to 6 minutes in the ICG angiography. So that's how you differentiate it from a window defect, which is actually a finding on fluorescein angiography due to RPE atrophy. Okay, the other, it's how common is this disease? So this disease, I think you're referring to PCV, because that was a question at 9:11 p.m. And it's relatively common in Asian population. So around about 30 to 40% of patients presenting as neovascular AMD. So in Hong Kong, China, Singapore, Malaysia, Thailand, Japan, Korea, and Indonesia, even India, they are quite common. And even in the States, in some population, for example, in those in Hawaii, they also see a lot of these in the Asian ethnic groups. So if you see an Asian patients presenting as neovascular AMD, think of PCV, because that could be in about like 30 to 40% of them are actually due to PCV instead of the typical neovascular AMD. All right, next question is on what is your opinion about macular buckle? Well, my opinion on it is that I follow what the Japanese nowadays are doing, because they have been doing macular buckle for many, many years. And they, in the last 10, 15 years, they also stopped putting in because they have seen the long-term complications. The patients with high myopia, they already have a thin choroid. And if you do anything compression, putting another buckle outside, although you can alter the shape of the staphyloma very well, but you get the atrophy later on. So yeah, the patient anatomically, they might do well, but visually they even do worse instead of doing some other surgery. So some of these patients, unfortunately, we cannot offer them any treatment, because the macular hole, we have done multiple surgery and still failed to close because of this abnormal shape of the eyeball. So those cases, even with successful macular buckle, they might not still see too well. So we still do not have very, very good treatment for these very severe cases, but nonetheless, fortunately, most of the cases are not that severe. And so for most of the myopic full field schisis cases with full field detachment, what we do is we do vitrectomy, iron peeling, and also gas injection, and most of them do reasonably well. Okay, so another question is on the benefits of peeling RM in myopic macular detachment surgery. So very good question. So the benefit of peeling the RM is that the RM is a rather rigid structure. Sometimes after you peeling, you can actually see the whole RM will actually, it's like a plastic sheet and it can roll up, curl up very significantly. So after peeling that, it allows you to flatten the retina better. So, and sometimes some groups have also done using that peeled RM to plug into the hole as a scaffold so that it can form a seal over the macular hole. So these are two of the benefits that can and another benefit is that when you peel the RM, you are making sure that any residual cortical matter, the very flimsy cortex, they are also vitreous cortex, they have also been removed, and those will not cause further traction to the macula. And that's why when people even peel ERM, occasionally they would also like to peel the RM so that the residual perimeter membrane on top would also be removed, and that will reduce the recurrence rate of the EM and also increase the success rate of these myopic macular detachment surgery. Right, another question. So can we diagnose a case of PCV without performing ICG based on OCT features? And of course, if you listen to the lecture, certainly. So if you would like to have further reference, so go to the APOIS paper that we published back in Ophthalmology in 2020. And that will show you the list of features on OCT that can be suggestive of PCV. And most of the time clinically, nowadays, I would say a majority of clinicians, they are doing the OCT alone to diagnose PCV. It's only when you really need to diagnose it for scientific studies, or if you plan to do photodynamic therapy, in those cases, you will need the ICG angiography, because to apply the photodynamic therapy, you need to have the ICGA to determine the spot size covering the polypoidal lesion as well as the branching neovascular network. And of course, for patients who are having very regular anti-VEGF injections or not responding to anti-VEGF therapy, you want to know what's going on. In those cases, you also would like to perform the ICG angiography. And in many cases, you might see the polypoidal lesions. And if you want to reduce the treatment burden, sometimes you would perform the PDT. But now we have more effective, more powerful anti-VEGF agents like brolucizumab and faricimab. In those cases, you might consider switching them to these stronger agents to see if it works for the patients. All right, another question, very interesting. So can PCV occur in older patients? Of course, so PCV can occur at any age. So younger ones, even like in the 40s, the youngest one I think I saw was 39 years old. And older patient, you can see it in an 80 or 90 year old patient. So any age it can occur. But generally, these patients with PCV are a bit younger than the traditional. So we've done study in Hong Kong comparing typical AMD, PCV, and the other subtype is retinal angiomatous proliferation RAP. So you can see that PCV mean age around high 60s. For patients, typical AMD about mid 70s, and for RAP, the patients, they usually low 80s, the mean. So a very good question. So they tends to be a bit younger, and therefore their sclera tends to be a bit thicker. Okay, another question. So in what age we can use anti-VEGF? So very good question. So in general, for patients with any form of CNV, we can still use anti-VEGF. So the youngest one I had, it's an idiopathic CNV. That patient was only about 8 or 9 years old. But so just make sure they do not have any systemic factors in terms of older patients, of course, because of very small potential of systemic risk. So you always ask for any myocardial infarction recently or cerebrovascular recently. And for younger patients, for especially the female, we also have to be careful because of the potential pregnancy risk. So patients who are female and also pre-menopausal, we would also ask for their pregnancy history. Although it's not an absolute contraindication, but for example, myopic CNV, they can occur in like 20-something, 30-year-old lady. And if they're pregnant, then you might consider waiting for a few months until the patients deliver the baby so that you can inject the anti-VEGF a bit safer. So usually first or second trimester, I'm a bit more concerned. Third trimester, if they're really threatening the patient's vision or the other eye, or it's already very bad, then you have to discuss with your patients and decide. And of course, for the youngest patients who need anti-VEGF therapy are those newborn with retinopathy of prematurity, ROP. So those patients, they use a reduced dose of anti-VEGF in these patients. So any age can have anti-VEGF agents. So another question is, sometimes CNV spontaneously heal without any treatment. So yes, it's possible back in the old days, but then once it becomes fibrosed and you get a big scar, and the patient's vision will drop quite considerably. So that's why nowadays with anti-VEGF therapy quite readily available, we should treat these patients with anti-VEGF agents because it's the best therapy for them. Especially for myopic CNV, the treatment demand is very low. So you only need 1 or 2 injections in the majority of patients. All right, another question on FA and ICG. So can you do them at the same visit or 2 separate visits? So very good question. So in most of the system, we would have both fluorescein angiography and indocyanine green angiography available. So even the flash camera or the confocal scanning laser ophthalmoscope, they would have the same the different set of filters inside within the same machine, so that you do not need to do them on separate visits. So a lot of times we just draw up the fluorescein angiography first, and then look at any leakage. If there's a feature suggestive of PCV or other pathology that ICGA is helpful, then we would also ask them to do the ICG angiography at the same sitting, so we can see both the retinal and choroidal circulation well. So another indication for ICG is, other than PCV, is of course the choroiditis. So they have been shown to be quite useful in some posterior uveitis cases. So another question on how effective is autologous transplantation of choroid and RP in CNV? I would say it's still very experimental stage, and if you look at the previous macular surgery studies, the outcome was just not as good as what we get in anti-VEGF therapy, because a lot of times you get actually visual worsening instead of visual improvement. And even if you have transplanted successfully, the underlying process will sometimes cause further CNV development, and you will still end up with patients needing anti-VEGF therapy. So at the moment, it's still not a mature treatment, I would say. So for CNV, definitely the current therapy is still using anti-VEGF. Okay, another question, very practical, good question. The recommendation for phaco and myopic traction maculopathy or myopic CMV patients. So I also do cataract surgery, and for these myopic traction maculopathy cases, if they are very mild, mild thickening of the macula and also no full field detachment, then those I would just perform the phaco for the patient first, and then a lot of them actually they recover quite well and see quite well afterwards. But if they have already have full field detachment, a significant metamorphopsia, then I would do a combination therapy if they need it for those with who are aged 50 or above. So I do a vitrectomy, RM peeling gas injection together with phaco and implant the intraocular lens. For myopic CNV patients, usually if they are already scarred, no active lesion, then those patients I would still continue the phaco, just do cataract surgery for them. But obviously avoid very significant fluctuation of pressure during the surgery, because that might sometimes cause some macular hemorrhage. But if the patient is having active myopic CMV with OCT, can show the active leakage with the subretinal hyperrefractive material, intraretinal fluid, subretinal fluid. Those cases, I would do the anti-VEGF injection first, treat them, and then once they are stable, at least like 3-4 months later, and then I would consider doing cataract surgery. Okay, another question is, how can we prevent ongoing increase in axial length? Okay, very good question. So unfortunately, with the prevalence of all the electronic gadgets and close work in these days, it's very hard to prevent it. And so that's why we have childhood myopia programs in Hong Kong. So hopefully with the use of various new glasses, so those peripheral defocusing glasses, and also with the use of low dose atropine, we can prevent some of these patients having increase in axial length. And a question on the peripheral degeneration, which of course I didn't have time to cover. So, so do you carry out laser preventive measure? So it depends on the patient. So if the patient's having retinal holes, for example, the other eye already have a retinal detachment, strong family of retinal detachment, those I would do a laser. But with very mild peripheral degeneration, no symptom, not symptomatic, I usually just keep on observing them having regular dilated fundus examination once a year or so for those high myopes. So depends on how high they are as well. For example, if they're like -6, so 1 or 2 is fine. But if they're like -10 or -15, then you might want to see them more regularly. And of course, warn them of new symptoms, any new flashes, or they see a shadow, then they should come to see you immediately. So another question, so myopic CME with glaucoma. So I'm not a glaucoma specialist, so but I think these patients with high myopia, they are prone to have glaucoma as well. So you should monitor them carefully for their optic nerve changes, and if in doubt, refer to your glaucoma specialist to deal with that. So and with anti-VEGF-A injection, sometimes it can cause a spike in the IOP as well. And that's why in some of the glaucoma patients, especially if they have very severe optic disc damage, we might sometimes consider doing anterior chamber paracentesis when doing the anti-VEGF injection, and also consider using some anti-glaucomatous drops to lower the IOP a bit quicker after doing the injection. So, and the question is, how often do you see vitreous hemorrhage after intravitreal aflibercept in PCV cases? So I'd say not common at all. So the rate, if you look at the clinical trials, is 1%. Or so in some of the bigger study, even in Luminous, which is the biggest study conducted as a pharmacovigilance study, and the rate is very low. So some risk factors can cause the vitreous hemorrhage. For example, you have multiple polypoidal lesions, pulsatile polypoidal lesions, or large PD, or patient on some anticoagulants. Those sometimes can result in bleeding, but it might not be due to the anti-VEGF agent, actually, because sometimes without treatment, the bleed can even be worse. So it's unfortunate. So sometimes these breakthrough vitreous hemorrhage, you will have to do vitrectomy to resolve them. Okay, so second last question. So how accessible is anti-VEGF in terms of cost and rural regions? So very, very good question. So depends on your country, of course, and nowadays it's more accessible in some places because of the availability of biosimilar. So you have ranibizumab biosimilar in some countries, so the price has gone down substantially. And of course, you can also use bevacizumab or Avastin, which if you don't have compound pharmacy like what we do in Hong Kong, we use a vial and share just before an injection. We group all the patients together to share them. So that will lower the cost quite substantially. But with the use of biosimilars, hopefully the cost will further decrease. Okay, and I think that's all. So thank you once again for joining this webinar, and send me an email if you're interested in anything on this today's topic, and I hope to see you in the future. So thank you very much.